This clinical vignette presentation is brought to you by the Drake University Student Chapter of the American College of Clinical Pharmacy, and it is titled The Role of Added Sugars in Cardiovascular and Metabolic Disease. While added sugars may have roles in numerous disease states, the focus of this presentation is on hypertension, obesity, and diabetes, which are often closely associated with other cardiovascular morbidities. First, it is important to recognize the prevalence and impact of cardiovascular-related morbidities. In the United States, just under 1/3 of adults are classified as hypertensive, and of those, only 52% are considered controlled. An additional 30% of adults are considered prehypertensive, so as a result, hypertension-related costs are estimated to be at around $49.6 billion annually. Obesity is also of increasing prevalence in the U.S. 35% of adults aged 20 and over and 17% of children aged 2 through 19 are actually classified as obese. Additionally, 8% of infants and toddlers are at what is called high weight for length. Cumulatively, the cost burden of obesity totals in at $147 billion for the United States, with estimated health costs for these individuals of at least $1,429 higher than non-obese individuals. Type 2 diabetes is also associated with obesity and other cardiovascular and metabolic disorders. 9.3% of the U.S. population is diabetic, and only 5% of that 9.3% is classified as type 1. So obviously there are a lot of type 2 diabetics out there. Additionally, 37% of adults aged 20 or older are classified as being pre-diabetic. Consequently, the estimated annual cost burden is $245 billion. Each of these disease states can be associated with a risk classification known as metabolic syndrome. So individuals with 3 or more of 5 risk factors classify for metabolic syndrome. So these risk factors are hypertension, abdominal obesity, elevated triglycerides, decreased HDL cholesterol, and an elevated fasting blood glucose. So if they have 3 of those 5, they are diagnosed. This diagnosis is centered around associations with fat deposited in organs, insulin resistance, and hypertension, and ultimately a greater risk for health morbidities. To avoid development of risks associated with metabolic syndrome, patients traditionally have been instructed to just reduce their intake of fat and reduce their intake of sodium. But this instruction may actually be misleading because there are a lot of variations of fat out there, and those fats have a variation of metabolic and overall health implications as well. So, we know that the incidence of obesity, metabolic syndrome, and diabetes have been on the rise for the past 30 years, but associations between this trend and adjustments in dietary habits actually presents an interesting challenge. So we know that daily caloric intake has increased. That's undeniable. But the percent of daily caloric intake from total fat has actually remained relatively unchanged. In fact, the percent of daily caloric intake from saturated fats has decreased. Meanwhile, high-fat, low-carb diets have also been found to reduce the risk for metabolic syndrome. So this presents an interesting case. The relationship between an increased incidence of metabolic syndrome and a relatively unchanged fat-related dietary intake indicates that while certain types of fat may play a role in metabolic syndrome and diabetes, little evidence currently supports that total fat intake is a cause. The traditional recommendation to reduce salt intake must also be considered with a bit of apprehension. While this recommendation is often given to our hypertensive patients, its effect on blood pressure has been determined to be clinically insignificant. So, additionally, reducing salt intake has no effect on triglycerides and actually may even increase total cholesterol and LDLs, which potentially increases other risk factors associated with metabolic syndrome. Because of this, a recommendation of 3 to 6 grams per day, no more or less, has been shown effective for decreasing the risk of death and cardiovascular events. This is actually inconsistent with the current AHA recommendations that say less than 1.5 grams per day. But this recommendation is reflective of the current Western dietary habits. Though traditionally not included, added sugars, which are sugars not naturally found in food products, have recently received more attention for playing a role in the development of metabolic syndrome. Current recommendations vary from 5% to less than 25% of total caloric intake from various sources, but studies have indicated risk associated with this range. So evidence indicates that consumption of 10 to 24.9% of calories from added sugars increases the risk of cardiovascular disease mortality by 30%. But even worse, while consumption of greater than 25% of caloric intake from these added sugars increases the risk for mortality threefold. So that's about 300%. So specifically, a fructose intake alone of greater than 74 grams per day is associated with a very significant increased risk of developing high blood pressure. This is particularly alarming considering the average Western diet includes a fructose intake of 83.1 grams per day. There is an important distinction to note between the consumption of added sugars, such as fructose, and natural sugars like glucose. After consuming glucose, 80% of the glucose will remain in the bloodstream, which causes a natural release of insulin. The other 20% of glucose will enter the liver, where a majority of it will be converted to glycogen for storage. The rest is packaged into very low-density lipoproteins for storage in adipocytes. While VLDL can increase the risk of atherosclerosis, only about 2% of consumed glucose enters this pathway, so it's obviously not very significant. On the other hand, fructose follows a different pathway. Instead of remaining in the blood, 100% of consumed fructose enters the liver. Once in the liver, fructose is generally not converted to glycogen for storage. Instead, fructose stimulates de novo lipogenesis, causing the production of VLDL and small-density LDLs in large amounts, contributing to hyperglyceridemia, atherosclerosis, and fatty liver disease. These effects have been related to that of ethanol. It also induces hepatic insulin resistance, leading to hyperinsulinemia and consequently weight gain and insulin resistance in peripheral tissues. Fortunately, virtually all fructose is co-consumed with glucose. Sugar found in food products is actually usually sucrose or high fructose corn syrup, which, as discussed later, contains similar proportions of both glucose and fructose. Fructose elicits responses that increases cardiovascular and metabolic risk compared to glucose and galactose. These include hyperleptinemia, hyperinsulinemia, and hypertension. Unfortunately, it is also sweeter compared to the other sugars, making it one of the more commonly used sugars in spite of these risks. High fructose corn syrup is one form of added sugar that has been investigated for its health implications. So in fact, in 2008, San Francisco attempted to place a tax on soft drinks based on high fructose corn syrup content. However, advocacy groups rebutted, citing that there's no evidence of difference between the health effect when comparing high fructose corn syrup and sugar. So you can see here, we respectively urge the proposal to be revised as soon as possible to reflect the scientific evidence that demonstrates no material differences in the health effects of high fructose corn syrup and sugar. So molecularly, these two sugars are actually very similar. High fructose corn syrup contains both fructose and glucose in approximately a 50-50 ratio. Sucrose, or table sugar, is a disaccharide which separates into glucose and fructose in low pH conditions. Ultimately, the metabolic effects are comparable. It is true that there are significant health consequences to the use of high fructose corn syrup, which have been found over the past several decades, but as demonstrated previously, it cannot be attributed to biochemistry. It is also true that, as the advocates against a tax on high fructose corn syrup in San Francisco cited, there's essentially no difference in health effects between high fructose corn syrup and table sugar. Rather, the issue is rooted in agronomics. High fructose corn syrup is much cheaper than sucrose, making it a very desirable product, leading to increased use in the food industry. An increase in use availability due to cost has led to an increase in consumption of high fructose corn syrup. This graph shows the prevalence of diabetes related to the availability of high fructose corn syrup. To put it simply, more sugar is associated with more diabetes. There's also correlation between increased availability of high fructose corn syrup and other cardiovascular diseases too, which are obviously not shown on this graph. A relationship can be seen between traditional strategies of counseling on sodium reduction and an increased consumption of processed foods. So when we're counseling people to reduce their sodium consumption, they will actually increase their consumption of processed foods. So in an attempt to meet policies that promote a population-wide reduction in sodium intake, there actually has been a reduction in sodium content of processed foods. However, despite these efforts, intake has remained at about 3 to 5 grams of sodium per day. This indicates that there's a psychological desire to maintain that intake. As such, the body compensates to maintain that 3 to 5 gram intake. When lower sodium foods fail to meet this psychological demand, individuals compensate by increasing their overall food consumption, especially of processed foods. These processed foods usually have higher sugar regardless of their sodium content. In fact, products labeled as heart-healthy processed foods with reduced sodium, or fat of course, generally do not have reduced sugar, and even worse, they might even have more sugar. Ultimately, these changes in sugar lead to increased cardiovascular and metabolic morbidities, which confirms recent suspicions that sugar may play a larger role in health than previously accounted for. Fructose is not only found in processed foods, though, and not all sugar is bad. So how does this work? Risks of consuming fructose in usual biological contexts, such as fruits, are not of great concern. In fact, intake of 200 grams of fructose in the form of whole fruit every day actually decreases systolic blood pressure. Additionally, moderate intake of fructose from natural sources shows improvement not only in blood pressure but also lipids, blood glucose, and insulin resistance when compared to a low fructose diet without regard for source. So the current theories about why this happens is that these effects are due to the presence of fiber in fruits. So the fiber will slow the carbohydrate absorption, decrease the insulin response, and ultimately increase satiety. In summary, we know that metabolic and cardiovascular disease continue to be of increasing prevalence in the United States, and that traditional methods of dietary adjustments focused on fat and sodium intake have proven to play only minor roles in cardiometabolic diseases. Instead, a shift of focus to fructose in the form of high fructose corn syrup appears to have a more significant role in these diseases. This is a particularly relevant problem due to the widespread availability and increased consumption of high fructose corn syrup. Moving forward, patient education is vital to differentiate between consumption of natural sources of fructose, which actually demonstrate positive health effects, and consumption of processed foods that contain high fructose corn syrup. Of course, as with all research, while the evidence is promising, there are a few limitations to the clinical application of these findings. First, sugar metabolism is a complicated process to study. In fact, most studies to date have not demonstrated a direct effect on sugar intake or metabolism on cardiometabolic risks. This is not surprising because while sugar may play a significant role in these diseases, there are many other factors that contribute to cardiometabolic health. Additionally, many of these studies are under artificial conditions, for example, comparing the health effects of intake of different amounts of pure glucose versus pure fructose that don't reflect the complexity of a typical diet. Attempts at developing artificial sugars to solve problems of added sugars are also challenging. While hopeful, these products are associated with higher costs and altered tastes. In addition, studies have revealed potential short-term health effects from the use of artificial sweeteners, which of course would make anyone a little bit worried about their use. And now we get to the role of the pharmacist. So the most vital role that the pharmacist plays in this area is patient education. It is important to inform patients of the current recommendations. According to the AHA, added sugar intake should be limited to 100 calories a day for women and 150 calories per day for men. This can present a huge challenge for patients, so offering suggestions like cutting out sugary beverages and processed foods, even ones labeled as heart healthy, is vital to providing them with the tools that they need for success. Again, this clinical vignette presentation was brought to you by the Drake University Student Chapter of the American College of Clinical Pharmacy. We hope that you can use this insight to improve your patient care. Thank you.